Yeah, I mean, I think they're really important elements of system reform.
Any other comments from the panel on that one? Okay. I'd like to shift gears a little bit here. You're probably wondering why somebody from Minnesota has been so quiet. So we're going to move to telehealth, and I wanted to leave a little bit of time at the end for some questions for all, so I think we'll be able to get through that and leave about 10 minutes for questions from you all on this topic that is, to me, mind-boggling. There's so much information here. So, Ahmad, patients are morphing into healthcare consumers and expecting to be more personalized care. What are some of the ways that consumers' changing needs can be met today?
Yeah, absolutely. So thanks, Eric. I probably have one of the best jobs in the country because I've got to figure out how to take digital health and engage consumers. Like Joe mentioned, the services that we provide at Optum are for a wide range of consumers, from the employer sector, Medicare, Medicaid, government. And one of the challenges we have is how do you start to take the digital assets when you think about what we all have an affinity for, and that's our cell phones and our smartphones. And how do we look and connect a consumer back to that device to help enable them to make the quality care decisions they need, not only within their caregiver, family, as well as with their provider. And so when I look at, and we look at other industries like airline, banking, travel, consumers are able to easily connect, schedule, do appointments. To the earlier comments that Joel made, right, the partnership with providers, really the challenge that we're working to solve is how do we close the white space between really the provider and the consumer as they're engaging in the healthcare ecosystem. And the challenge that we're solving and trying to work on very aggressively, when you think about all the good comments that were made this morning, is when a consumer or patient isn't in front of their provider, how can they share relevant data and information to close what Joe and Joel had mentioned, the gaps in care, to make sure that their chronic condition management is handled effectively. And then how do you start to create a caregiver dashboard? A lot of our consumers and patients are asking for that, so that if mom is discharged from the hospital but her children are across the country, how can we start to use a platform that enables that dialogue and sharing of information throughout the ecosystem? And we're seeing a lot of more interest in the market clearly around that. And then I'd finally say kind of the other pieces that we're working through from a consumer expectation perspective is really how do we build a supply chain, so to speak, into the consumer's home. So when you look at what Amazon's doing with Dash, the ability for consumers to hit a button and have product come to their home, we have to, the expectations that consumers are having across our business lines is how do I age in the home? How do I take care of myself in the home? How do I bring the caregivers that are there to the location where I'm at? And so we're moving more in-field as it relates to that service delivery and the expectations that we have from consumers.
Well, and my wife sends a question. She really hates filling out those long forms in the doctor's office. Are you doing anything to kind of standardize that, fix that,
great,
and make it transportable from one doctor's office to another?
Yeah, absolutely. Great question. So this lends in a couple other comments as we kind of look at the ecosystem from a telehealth perspective. The ability to, twofolds, the ability to take the virtual visits and the data that comes in from that virtual visit with the provider, along with the EMRs and any forms that are filled out, we want to upload that all into what we call the Optum Telehealth Cloud. We have a cloud-based environment that right now we're servicing close to 20,000 chronic condition patients. So the ability to not only manage that consumer or patient, but also the ability, to your point, to gather that information when they fill out the forms is something that we are working on very aggressively.
Okay, from a telehealth perspective, what is Optum doing currently in the marketplace today? And how does that approach become kind of relevant to more than the 20,000 you have?
Yeah,
It
absolutely.
sounds like the 20,000 is like the 200 million that we heard earlier.
Absolutely. So when you look at what we're doing in the market today, from an acute care perspective, a consumer is able to use their smartphone today and connect with a virtual provider for an acute care need. That also includes not only the technology, but also then importantly requires the virtual network of physicians. And one of the opportunities we're continuing to see is how do we potentially designate that virtual centers of excellence, no different than when you have a cardiac or spine centers of excellence. The market is asking us to help define not only the access, but then also the quality care aspect of that within our physician network that are doing those virtual visits. And then what we're also seeing in the market and that we've started to do is the medical behavioral integration as part of that virtual visit that a consumer comes in through on our Now Clinic platform. So that's the acute care side. On the chronic care side, for heart failure, COPD, and quickly what we're also prototyping is the ability for a consumer to hook in a dongle device into their smartphone for blood glucose readings that then uploads into the cloud-based environment. And then what we can go back to the collective dialogue is say to the provider, Dr. Jones, here's your patient panel of your top 20 diabetics that we can work in partnership with you to help enable the care for that consumer. And so really it boils down into kind of three things. It's the technology, but the technology alone is not sufficient. It's the technology, the smart care team or clinical team that supports that consumer and the provider in the market. And then what we're learning is the workforce management that a provider has to now deal with based on the instant gratification that a consumer has with connecting through their device back into their practice. So that's been something that we've been also working with different practices across the country. And in my humble opinion, the new consumer is actually becoming the provider. Because if we can better partner and work with that provider community and the hospital systems, and to Joe's point, if we can get back more upstream into the hospital discharge and really meet that consumer at the point of care, that's where we believe we can continue to make a fairly significant impact in the ecosystem to help not only the provider but the consumer.
So are you seeing consumers embrace this, and does that embracement work all the way from millennials up to
Yeah, great question.
the
So,
great generation?
right, we've been seeing over 90% satisfaction with our virtual visits on the acute care. With the tablet-based solution for our chronic, we have over 85% engagement. So we drop ship the tablet-based solution with symptom questions. We make the symptom questions very user-friendly and easy so that if a consumer is stepping on their wireless Bluetooth-enabled scale, all of that information and the ease and access has been well embraced by the market, and we're going to continue to do studies to see how that's impacting our MedX savings and value proposition as we continue to move in the market. But we are very, very pleased with the initial rollout that we've done on this to consumers, and they've been well adopted. And what we're learning is we've done simple enhancements. For example, with the scale, we've added a handrail so that a consumer can step on it. We've done now Spanish symptom speaking questions, voice-enabled recognition to help the older population as we move into market, and those have been well embraced.
So do you all feel like you've just entered into an episode of the Jetsons?
Yeah.
This is amazing stuff.
It is, and I just think the ability for us then to take all of the data that's going to be within the cloud-based environment and integrating it back into the provider practices is going to really become our new engine of innovation as well. So we're starting to collect symptom questions, biometric readings, blood glucose readings, so we can start to understand when do consumers step on the scale, when they don't step on the scale for heart failure, et cetera. And so from that, we're going to start to look at the data and start to say, what are other areas we can start to tweak and enhance the innovation around our digital agenda to help consumers really take better care of themselves and to the collective dialogue close their gaps in care, because that ultimately is the true value prop that we believe we're bringing into the market.
So you've got a lot of these products rolled out now. What's being looked at in your research and development area?
Yeah, so diabetes is probably, as we can all appreciate, is probably one of the most challenging chronic conditions that we have to service our consumers and patients on. So the focus right now is we've done, as you can appreciate, with technology comes its challenges. What we're learning in the market is consumers have an affinity with their own blood glucose meter, Bayer, J&J, Roche. So what we're prototyping right now is the ability, it's like if you go to a great restaurant, if that meal's not good, you're never going back again. So what we have to make sure is the connectivity and the prototyping of the different blood glucose meters back into the smartphone, the wireless enabled and the Bluetooth enabled. It's the Bluetooth interference is somewhat of a challenge. So we're working through that. And then the ability to do the clinical dashboard alerts on those blood glucose readings is really our major focus. And then the other piece that the market is really asking us to do is how can we help, and not necessarily for this population, but more for our commercial, is maternity mom. How can we help moms better manage high-risk pregnancies? And that's another area that we're continuing to innovate and ideate on.
So what I'm envisioning is kind of a dashboard where you go pick the things that are bothering you as an individual, and you plug those in, and it does tracking for that type of disease and asks pertinent questions for your continuing care.
That's absolutely right. And I think, when I look at the market, it's moving more from acute to chronic. It's moving more from prevention wellness into chronic. And the ability to enable the wide spectrum of what we service across our ecosystem of over 40 million Americans, how do we create a digital platform and asset? And I would say not only the challenges that there are with the technology, but then how do we create an advocate or a Sherpa to work with that consumer and patient as they're going? Because really 15% of this, from my humble opinion, is technology. It's what's the clinical platform, the clinical care team, and how do you bring all that together in the ecosystem? That's what's intriguing, that's the challenge, and that's what keeps my team really pumped up to come to work every day.
Wow. Just amazing stuff. Joel?
And first, I want to say that Blue Plans, and I think this is true of plans generally, are extremely excited by these technologies. And they form a perhaps essential part of a value-based payment program. I mean, if you're trying to improve the ability of a medical home to take care of patients with chronic conditions and multiple morbidities, the technologies that you're talking about will help that. The danger is if we take technologies like this and layer them on top of a dysfunctional, fragmented fee-for-service system, then everything that's wrong with fee-for-service medicine today is going to be amplified by these technologies. These technologies could actually lead to higher costs rather than lower costs, more visits virtually than fewer visits. So it's really important from a plan perspective that these technologies be harnessed in a way that they are part of and support, value-based models, medical homes, ACOs, bundled payments, whatever is coming next.
Yeah, Joel, I think you bring a really relevant point, and the concept we always, from a product development, is crawl, walk, run. We have to work closely with our provider communities to test this out, exactly to your point, is really mission critical for this to be successful, because you're right, if we start to just jam down the technology without thinking about the full implications, that could have impacts. But we are definitely taking a methodical crawl, walk, run in terms of what are the results, what are the impacts we're seeing, and then how do we also work with our United Healthcare partners, both internally and our external payers, around reimbursement policy, et cetera, to make sure that we are really bringing the right value to the market.
Lee?
Yeah, let me just make a policy comment, which is, so when we sort of going back to prices, and there's this whole issue of concentration of markets, and if you talk, typically you talk to an economist about how are you going to deal with that. One way the sort of classical way to deal with that is have new entrants to the market, have new providers, and telehealth, is a way of doing that. And I think if you look at from your all perspective, if you look at how telehealth is regulated at the state level, there's not very much consistency. So that's really a sort of a challenge, is how to treat telehealth from if you've got a small practice, you're using telehealth, maybe you're in a rural area, and how do the licensing laws and the scope of practice laws apply to you using telehealth? And that's something that's going to be decided state by state.
As it should be. An editorial comment. Okay, we've got about 10 minutes left in this session. I'd like now to turn it over to you, the audience, because I know my mind is spinning from all the information we've gotten here. It's amazing stuff. So let's have a question. And the first two questioners pick one of the prizes.
Oh, great.
All right. So
I want to introduce a little note of skepticism to the Jetsons' enthusiasm, because we've been reading a lot about government websites being hacked. Suppose I am going to a psychiatrist getting an antidepressant, or I'm going to an internist and being treated for a sexually transmitted disease. Why should I have any faith that the Optum system could safeguard my information from being hacked by skilled hackers, of which there are many? Why should I even want it to go out of the doctor's office onto the cloud?
Yeah, that's a fair question. So let me say that 2/3 of consumers today aren't very familiar with telehealth and the ability to connect. And so there's part of the market is still very nascent. And as we work to deploy our products and offerings into the industry, what I can tell you is, from a United Health Group perspective, our security standards, our protocols of what we do before we launch our products into market are fairly aggressive. I think part of this paradigm shift and the need to create the comfort, as you were alluding to, is the more that we can partner with the provider community and help educate them on the security protocols and standards we have, and then when they sit down with their patient to say, the next time we could have a virtual visit through this technology that we know is secure, is a way to overcome some of those concerns and valid points that you raised. But I can rest assure you that the things that we're doing in terms of our security protocol is very rigorous and is part of our agenda.
yes.
Thank you. Yvonne Hunter from Arizona. I had a couple of questions, one of which was already somewhat addressed on the secure system for the telehealth. But we have a healthcare appeals process, and oftentimes the records are voluminous in production and what have you, and they have to be transmitted from the provider to the insurance company, oftentimes to the agency for further review. Is this telehealth process amenable or adaptable for that kind of transmission? And then I had another question.
Yeah, absolutely. So we have the ability to transfer, to your point, the voluminous records as part of, if there's any questions as it relates to the quality clinical standards of what we're deploying on our telehealth platform. We have successfully done that in numerous situations if that comes up. So I'm very confident that we can pull those records as needed.
Yeah, hey, excuse me, let me add to that, because what you're really touching on is this larger issue of interoperability. And suffice to say, we are not where we want to be. A lot of EHRs, electronic health records, don't talk to each other. health plans have been going through conniptions trying to combine claims data with electronic health record data. I mean, what you're talking about is really difficult. One thing coming that may help is that HHS probably next year is going to issue a proposed rule on claims attachments. And this is a required HIPAA transaction for sending follow-up data. So, oftentimes a claim is rejected because the physician didn't provide a lab result, and whether or not something is medically necessary may depend on the lab result. And these new transactions that CMS is going to be proposing are going to establish standards for sending this sort of information. So that should help. But as to interoperability generally, it is a tough one.
Thank you. I was just curious in terms of how that would technically work. The other question I had deals with vertical integration. When you're dealing with a rural area that may have very few providers, maybe a hospital in that, for example, Arizona, we have counties where there is not a hospital. How does a patient have faith that they're getting the best decision when the options from the beginning, even without vertical integration, are somewhat limited? And I would be curious to have your input on that.
That's a very good question. What's the next question then?
No, I mean, I'm not. That's an issue, and I'm not sure it's limited to vertical integration, right? I mean, this isn't also. That's just really a sort of a capacity issue. If you're in a very rural area and there may not be enough providers, and it just may be an underserved area. The integration may not change that. It may change the economics of it, and it may increase the prices. And frankly, so can the horizontal mergers. If you have the only provider in the community is part of a statewide or national chain. So it's from a consumer. It's more of a policy economics issue than it is a sort of consumer issue.
Yeah. And from a plan benefit design, certainly this is where telehealth can play a huge role, particularly for behavioral health, where psychiatrists are few and far between in many rural areas, and where there are psychiatrists, they are not contracting with health plans because they don't have to. The other is a lot of plans and employers are implementing innovative benefit designs around transportation, so that no, it's not ideal that someone may have to travel, but there are companies like Walmart now that are paying for their members to go to the Cleveland Clinic. Now, this isn't only their rural members; they're trying to steer all of their members to the Cleveland Clinic because they can cut a really good deal, increasing volume to Cleveland Clinic, and the Cleveland Clinic is, of course, a leader. But just think about the potential in a rural area if the plan that's ensuring that person who doesn't have a nearby hospital or the hospital isn't particularly sophisticated is enabled through a transportation benefit to go to a tertiary care facility that's high quality. So, these are things the market is thinking of and is working on, and hopefully Medicare. We were talking about changes in the Medicare benefit. Gee, a transportation benefit in Medicare might work very well. Certainly, a lot of Medicaid plans have something like that. So, tough question, but there are people trying to think of different ways of getting at it.
Or you could pay for your Uber driver to get you to the doctor's office, right?
Yeah, Uber X.
Yes.
Not Black Car.
Well, I'll ask you a vertical integration question. I'm Mary Childers from the Washington State DOI, And so I wanted to ask you what you saw for the future of narrow networks and how that works with vertical integration. I will tell you in Washington State, as part of ACA, the carriers did adopt some narrow networks, and the result was it lowered, kept premiums down on the exchange policies. Very good thing for consumers. We got a lot of complaints, but they didn't come from consumers. They came from providers. And what they claimed was their patients weren't getting access to care because of narrow networks. We investigated those complaints very closely, couldn't find any evidence that that was the case. But they are under attack. The providers don't like the networks. They don't like pre-authorization. They don't like utilization review. They're not too happy about being tiered either. So where is this all going?
Mary, I meant to say 3, so you get a prize too.
Yeah, okay, a couple of ways to answer that. First, nobody likes change. It's incumbent on payers to be transparent about what they do, I think. So when a payer sets up a tier, the providers need to know what the criteria are for going into one tier or another. Or when a provider sets up a limited network, it only helps relations all around if everyone understands the thinking that went into that. Well, you've answered, I thought you were going to ask a slightly different question. Your question answered that, yeah, there so far is no evidence that so-called narrow networks on the exchanges have led to any problems in quality. One of the interesting things that's happened in Washington is reported by one of our, there are 2 Blue Cross and Blue Shield plans in Washington State. One of the Blue Cross plans tells me, I was talking to their network executive, that when they first established their network and they bargained hard and they made a narrow network, and then other hospitals started to see their patients going to their competitors. The following year, hospitals that previously said, no way are we going to offer you a deeper discount, came back to the Blue Cross Blue Shield plan and said, we're ready to offer you a discount. So this particular Blue Cross Blue Shield plan, what started out as a narrow network is now a broader network, but the premium hasn't changed because the other hospitals lowered their prices. So, you get some interesting market dynamics when a health plan changes its benefit design and changes its network that could ultimately benefit everyone.
Yeah, so this is just basically your big economic struggle, right, between payers and providers. And the providers have tried to get more strength in their negotiations with payers by merging and by getting bigger. Payers are striking back by doing things like narrow networks. And one thing is, I think there's different kinds of narrow networks out there, right? So, for example, CalPERS, the big retirement plan in California, has done some things with providers where the medical services are sort of almost commodities. Things like knee and hip replacements, where there's just a lot of volume, and they've said, okay, these are the 5, 6, 7 providers that provide excellent quality at a lower cost, and they charge up to a certain amount, and we're going to pay up to that amount. And if you want to go to a different provider that's not on this list, we're only going to pay up to that amount, and the consumer pays the difference. So there can be narrow networks that have different kinds of degree of economic risk for the consumer in terms of how much they have to pay if they go out. But I think the other issue here is in this struggle between providers and payers and who's going to have the economic upper hand and what that means for premiums and things, where are the states? I mean, there's certainly some policy tools that states could use to address vertical integration and horizontal integration that has led to higher provider prices. So whether it's sort of soft sorts of things like all-payer databases or monitoring of state of mergers or monitoring of premiums to more, let's say, heavy-handed, more regulatory approaches like global budgeting and things like that. There's a whole range of things that states are looking at, and the more they're willing to intervene, perhaps with some of those policy tools, it may take away some of the momentum towards higher prices that has really driven plans to try and figure out a way to regain some economic strength in those negotiations.
Yeah, thank you. Please join me in thanking these folks. I think they did an incredible job. There's a ton of information in there and lots of potential solutions, lots more issues than solutions, I think, at this point. We're going to have to look forward to how healthcare is going to evolve. We've seen some of the new technology with telemedicine and the pricing issues, the public policy issues, running a network, running kind of not only a healthcare network, but running a computer network and the issues that can bring as well. So please join me in thanking this group.